Syncope is the temporary loss of consciousness and tone followed by a complete recovery after a brief period. It occurs due to inadequate cerebral perfusion. It's a common complaint in older children and adolescents. 15 to 25% of children and adolescents report at least one episode before adulthood, but is unusual in children less than 6 years of age. The most common cause of syncope in the normal pediatric population is neurocardiogenic syncope, that is vasovagal syncope, fainting. Approximately 30 to 50% of children will have had a fainting episode before 18 years of age. History: inquire about events, for example eating, voiding, stretching, and position, including a change in position prior to the episode. Duration of loss of consciousness, associated symptoms, for example pallor, palpitations, headache, shortness of breath, nausea, diaphoresis, amnesia, vision changes, and time since the last meal. Environmental factors, for example warm temperature, crowded environment, noxious stimuli may be helpful. Syncope associated with exertion or exercise is ominous because it may indicate a serious cardiac etiology. A thorough evaluation is always indicated. Syncope in the absence of pre-syncopal symptoms should be approached with a similar level of concern. A family history of sudden death, sudden infant death syndrome, heart disease including congenital arrhythmias, deafness, seizures, and metabolic disorders may be helpful in the diagnosis. Personal and family history of prior episodes of fainting are often obtained in cases of benign vasovagal syncope. A menstrual history should be obtained in females to investigate the possibility of pregnancy. The social history should inquire about the possibility of ingestion or illicit drug use. Inquire about access to any potential toxins or medications, including medications of other family members that might be accessible. Diuretics, beta blockers, other cardiac medications, and tricyclic antidepressants are medications that may lead to syncopal events. Examination. The physical examination findings are usually normal in children who experience syncope. The examination should include a thorough neurological examination, and the cardiac examination should be performed with the patient supine and standing to rule out an obstructive lesion. Investigations: perform ECG, orthostatic BPs, plus minus urine HCG in adolescent girls. If the results of the investigation normal and there are no signs or symptoms suggestive of cardiac etiology or neurologic disorder, then refer to cardiology for consideration of tilt test. Reflex syncope, that is vasovagal or neurally mediated, is defined as relatively sudden changes in autonomic nervous system activity that leads to a sudden decrease in BP, heart rate, and cerebral perfusion. It's an example of neurally mediated syncope, that is vasovagal. Diagnosis: vasovagal syncope is classically associated with a prodrome that includes diaphoresis, warmth, pallor, or feeling lightheaded, and is often triggered by a specific event or situation such as pain, medical procedures, or emotional distress. This type of syncope is characterized by hypotension and bradycardia. Most patients with a vasovagal syncope episode will have prodromal features followed by loss of motor tone. Once in a horizontal position, consciousness returns rapidly in 1 to 2 minutes. Some patients may have 30 seconds of tonic-clonic motor activity, which should not be confused with a seizure. Treatment: therapy for vasovagal syncope includes avoiding triggering events if possible, fluid and salt supplementation, and if needed, midodrine, that is alpha-1 agonist, produces vasoconstriction. Immediately after the event, the patient should remain supine until symptoms abate to avoid recurrence. Prognosis: it's very common in adolescents and has an excellent prognosis. So what's the summary of the topic? Vasovagal syncope is also called postural reflex, neurocardiogenic, or neurally mediated syncope, or simply fainting. Some overlap in terminology is occurring with increasing understanding of the pathophysiology of orthostasis, the body's adjustment to upright posture. It's the most common type of syncope in normal children and adolescents. It occurs most frequently in the 15 to 19 years old age group. A neurally mediated decline in blood pressure, the exact mechanism of which is poorly understood, and heart rate are responsible for the transient decrease in cerebral blood flow, leading to the syncopal episode. Recognizable precipitating factors: rising to stand, a prolonged period of standing, certain stressors like venipuncture, noxious stimuli, fasting, or crowded location. And prodromal presyncopal autonomic symptoms: For example, nausea, pallor, diaphoresis are characteristic of this type of non-cardiac syncope. The absence of a prodromal or presyncopal sensation is not consistent with the vasovagal etiology and should prompt consideration of more serious etiologies. Also, vasovagal syncope can occur after vigorous, usually prolonged exertion, such as at the end of a long competitive run, due to a warm ambient temperature, venous pooling, and dehydration. It's distinct from mid-stride syncope, which should prompt an immediate cardiac evaluation. Most of these cases have a vasovagal, not cardiac etiology, but sports participation should be curtailed until a worrisome cardiac etiology has been ruled out.